All right, welcome back from the break. It is time for the great debate. And this time, the debate has a very specific topic. Genomic information is essential to clinical assessment of complex disease risk. So that's genomic information is essential to clinical assessment of complex disease risk. Now, in the pro corner, he is the answer to the medical trivia question, what is the relationship between RSV and heritable cancer? He is the bruiser from Bethesda, Steve Chanock. Hello. Now, among Steve's many titles, he's the chief of the NCI Division of Cancer Epidemiology and Genetics, and a whole bunch of other great things. You can read about it on his Wikipedia page, which was not edited by him, so don't even think that. In the con corner, his last name is Hawaiian for abundance of data. It's the great kahuna, Zach Kohane. So again, Zach, many different titles. He's the inaugural chair of the Department of Biomedical Information and the Marion V. Nilsson Professor at the Harvard University, which is not the Ohio State University. And so he'll be taking the con. So the format is maybe a little different than you've seen before. It's similar to if you golf. The first person, Steve, will give a 10-minute presentation on the pro, followed by Zach doing a 7-minute rebuttal. It'll then switch. Zach will do a 10-minute presentation on the con, followed by a 7-minute rebuttal, and then it is a free-for-all. One additional thing before we started, no throwing chairs at any time during the debate, so we'll leave it that way. Anyway, Steve, over to you.
All right. Pleasure is a hard word to use, but certainly it is fun to be here. So why don't we have the first slide here in Washington, okay? All right, here in Washington, everything is political. So we're going to use standard operating procedure, and I'm going to start by...
But you have to stand by the mic.
Sorry, I'm going to start by smearing my opponent before we talk about any facts whatsoever. So really, we'll begin with data from Cambridge Analytica, aka Harvard Medical School. And I just wanted to say this, who is Zach Kohane? I knew him when I was a fellow and he was a resident, so we've known each other a long time. This young, handsome guy, and this is his more recent picture. And the question is, who does he look a lot like? Well, Larry King, to me. Okay, Larry King has been in many different places, and as a commentator, you have to wonder really what is it that Larry has to say. He was on CNN, and now he's got some other shows. But Zach, unfortunately, is going to represent Fox News today. It's fair and somewhat balanced in his view. So I just want you just to take that into account, that you're going to get a lot of pseudo fake news from him today. And in my rebuttal, I will be able to try and come back on some of the things that he said. But it's a tall order, okay? So let's get back to the basic facts. Not the fake news, non-genetic news that you'll hear in a little bit, but the power and the importance of genetics. So really, I want to start out with this point that we've talked about earlier today, that all diseases are complex, human and non-human. And I'm sorry that Naomi didn't get a chance to tell us more about cows. I think we have more to learn from cows than we would like to know, particularly in 2016 to 2020 election politics and how genetics influences behavior and thought processes. It would have been really interesting to get into those complex disorders. But historically, I think I want to make a couple of points. That genetics handles time very poorly, and most of our models are broken. As Bach said, all models are wrong, just some are useful. And the question is, in what context do we look at a model using genetics? And time is always a difficult thing. Emmerich showed some very interesting data today. This sort of first attempt, I think, at starting to try and understand genetics over the arc of its time. And I also think family history is very important. It's a superb surrogate for genetic background. Shared exposure is clearly there. I'm not denying that. But it's a very important thing to consider. So when we look at our complex diseases, family history is absolutely crucial. And as we go forward, I think genetic susceptibility and its relationship to precision medicine and precision prevention is still under construction. So I'm going to argue that we're in a point where Pandora's box has been opened. We can't put it back. We can't go to Fair and Balanced, Sean Hannity, and think about things 50 years ago. We have to think about it in 2019. Where do we go, and how can we use effectively the tools that we have? Because any physician who's in a room has an obligation to think of what are the available facts, not necessarily just from an RCT, but the facts at hand to try and make the best decision to help that particular patient or that population. So the arc of genetics, really, we have to keep in mind that it goes through stages from discovery to validation to clinical use. And so where are we in the arc of genetics? We have discovery going wild in all sorts of corners, lots of very exciting discovery. The validation is taking place, but when and where and how we move to that genetics, I think, is a crucial thing. But there are plenty of examples. We can't stop the power of this curve, okay? And so we know that there are plenty of myths that no one technology can do it all. I know we'll talk about that tomorrow. No single study tells it all. UK Biobank is great at hypotheses, at testing certain things given its size, confluence, some of these other very large projects emerge. But you have to bring things together to be able to intelligently link the different parts of genetics. So this is the most complex slide, the genetics in context in 2019 and beyond. We know that really genetics is really interesting in the context of absolute risk, okay? We talked about relative risk and estimated odds ratios, things that we use to try and justify the studies that we have, but we always have to think about where and how does that absolute risk come in, and how can we study that, and more importantly, use our data, whether it's in the context of screening or within the patient room having that conversation. And I think there are examples of each of them, and we heard about that today for AF, we heard about that for breast cancer, which I'll come back to in a little bit, and heard about it for Alzheimer's. So I think the cat is out of the bag. It is, to use another euphemism, Zach, that's going to be hard to put back in there. So common disease and rare diseases is how we've broken them down, but there's a space in between. So the challenge is how to apply this genetic knowledge, and we have to think about the individual setting and the public health genomics, and what are those specific recommendations for an individual versus a stratification in a public health decision. And this is where observational and real life data is crucial, whether it's in publicly available data sets or in commercial data sets. There's a lot to be learned from there that we can use. We can't do an RCT for every single question that we want. There's not enough money. Now, I play the lottery every week, and I have since my kids were doing Little League Baseball when they're 7, now he's 36, thinking every week you play one ticket, thinking you're just one ticket away from winning it all. We've never won it all, but there may be a day when we will win it all, and then I'll give my money to being able to do RCTs on all the different questions that we want. But until that comes along, that ain't going to happen, and NIH isn't going to do that. So the real question is, the current paradigm, can it change this inverse relationship between incidence and risk stratification? For diseases that are very common, we think of wanting to use risk stratification. For very uncommon diseases, we can't do that. So I think we have to think about the context of what genetic question or where genetics can be applied per se. So precision medicine versus precision prevention is individual versus states' rights. What are you going to do for the larger versus the individual? We know that the value of family history is clearly there for cascade testing and going to the next step, but the value of these risk factors, whether they're measured or whether we have Mendelian randomizations for intermediate steps or lifestyle, we know that we are learning more and more, and their paradigms are being developed at this time, and there are clinical implications to these right now, okay? So pharmacogenomics and pharmacogenetics, we have early examples of using this, whether it's for predicting malignant hyperthermia, factor V Leiden, cancer therapy, irinotecan. There are a whole series
1 minute
of things.
warning.
Okay, well, I have 2.5 on my thing up here.
Oh.
Yeah.
2.5 minute warning.
Okay, thank you. Thank you. Thank you. Thank you. Yes, exactly. Zach put you up to that, correct, right? That I think that the ability to use this both for efficacy and toxicity is already, we're starting to see the very first examples at. So let's take something like cancer. clinicians back in 1860, Paul de Broca, the great neurobiologist, noticed in his family, his wife's family, some 14 or 15 cases of breast cancer over multiple generations, and saw that there was something before we had the idea of genetics. And then we had twins in family studies, and then Li-Fraumeni syndrome, the Knudsen hypothesis, and the mapping of familial breast cancer that really started the ability to be able to test genetically and have important implications for clinical things. So now when we look at breast cancer, that we know that absolute risk in 1 in 8 women, we have to start to break it down. It's a complex disease. There are women who have PRSs that are very important, as Monsi showed. There are women, up to 5 to 10% in the population have actionable BRCA plus other HRD-like mutations. So we have to ask this question, how do we break this down if we're looking at the population level, and how do we use that when we go into the actual clinics? We know that there are modifiable risk factors that are targeting for PRS to be able to decrease that risk. And then the one thing that we really haven't talked about is the importance of somatic mutations, which are drivers for targeted and immunotherapy, multiple subtypes, and mutational signatures. Just today, there's, I'm going to go through, I'll wait. Just today, there's a paper of looking at mutational signatures, being able to work backwards and identify women who have BRCA and other mutations in Nature Genetics as a clinical entity who actually respond well to PARP inhibitors. So there are therapeutic decisions made on those kinds of things. At the same time, we know that panel testing is breaking out all over, and we don't really quite yet know how to apply this in all the different places that we want to. But it is here clinically, and it's happening in thousands and thousands of women. So how we put this together with our genome-wide association studies, I think, are going to be very, very important to be able to ask the question, where can we start to modify diseases like breast cancer, which are occurring in 1 in 8 women. All right. So I just want to make one last point here. As we talk about genetics are here to stay, I want to make a really controversial point, and that is I think that we need nationalized health care, and genetics are going to take us there on the Schumer-McConnell conundrum here. So here are these guys sitting here. This is what McConnell's thinking. Damn it, why are my premiums 3 times yours when he's looking at Chuck Schumer? Well, he's got strong family history and the wrong genetics for prostate, congestive heart disease, and things like that, and Alzheimer's, whereas Chuck Schumer is saying, lucky me, I have a better family history. And to be honest, this is a very un-American concept, the idea that we're going to separate populations on the basis of their heredity and not on the basis of the equal opportunity they have going forward. So this is why we need nationalized health care, and this is why genetics is here to stay. All right, Zach, it's your turn, pal.
Thank you. All right. So on the date a half-American prince was born, we can move to the rebuttal. Yes, any of you who have a teenage daughter already knew that the prince was born because your texts were blowing up. And I thought it was something with Taylor Swift, but it was actually the prince. The prince was born. It was a prince. Yes, you'd be happy to know that, Dan. I know you're a big Anglophile. Yeah, you're a French Canadian. Yeah, that's right.
The clock should be running. I mean, he's already 2.5 minutes into his rebuttal time, right? I went to a Quaker school, so I guess it's like a Quaker meeting. We're waiting for him to stand and speak, but it started a while ago.
All right.
All right, Professor.
All right. First of all, so my 7 minutes are starting now. First of all, Steve, I want you to know I made sure, despite your self-immolation tendencies, to actually not tweet out anything that said Fox News on it or anything about national health care. The one thing that's out there should be okay for the rest of you. All right, no need to thank me. So, rebuttal. I am the first to say that there's a lot of value in genetics. After all, I can tell you about this child that was seen who was growing up not walking, was growing up walking and talking, and then he stopped walking and talking. And no one understood why. He was referred to the Undiagnosed Disease Network. I have the privilege of being one of the PIs of the coordinating center. And we found that he had a mutation in a specific gene expressed in the brain that if you give some neurotransmitters, you can overcome the problem. And this child started walking and talking again to the point that his parents were not used to it. He fell down the stairs because they were not used to their kid being able to get around. So genetics really works for highly penetrant diseases. What are we talking about? I think the title said complex diseases, and I think it said clinical. So it really, really works. And not only that, as we showed in the New England Journal paper, it's not just the fact that we have the genetics, it's that we have experts who now know how to interpret it. Because in fact, 30% of the patients referred to our network already had genomes or exomes, and those were not correctly interpreted. Which brings me to someone who I think we have to recognize. This is a painting done by one of our famous American portraitists of an imagined view of an imagined character. Voltaire wrote a book called Candide, where he has a Dr. Pangloss, who he created to make fun of Leibniz, who had postulated that we live in the best of all possible worlds, because as he had developed calculus, that all these bad things were happening, had to happen in order to come up with the best possible world. And this character, Dr. Pangloss, throughout this book, Candide, keeps saying, we live in the best of all possible worlds. Even while the Portuguese earthquake of that time was happening. And that reminds me of someone. Yes, 1986. I knew him well. A year later, I was an intern. He was a fellow. And he really was Dr. Pangloss. And let me tell you, he had to be. Why is that? Because we were in the middle of the AIDS epidemic. And we had children on our service who were dying. And we did not have a single drug. The drugs were going to come 3 years later from the FDA. And you had to be Dr. Pangloss. You kept having to repeat to yourself, I'm living in the best of all possible worlds, in order to actually be able to care for these kids who we knew all would die, and they did. The problem is that early exposure has made him Dr. Pangloss for the rest of his career. And he takes this unreasonable optimism to the present that causes him to not distinguish well the present from the future. And this will have dire consequences. As I articulated with my colleagues Dan Macy's and Russ Altman in 2006, I said, you know, even if we take the world's best genomic test, a test that is, I'm going to give you a test that's 100% sensitive, no false positives, no false negatives, and 99.9% specific. If you merely had 10,000 tests in parallel, 60% of the United States population would be falsely positive. And I said, you know what? Maybe you don't care about the patients who are going to scare the crap out of. Maybe we don't care about all the doctors who are going to annoy them by getting all these phone calls about, oh, do we really have to repeat that mammogram? Oh, do we really have to get the ultrasound? Maybe we don't care about them. But then, when insurers get wind of this, and they start saying, not only are we not going to pay for your tests, genetic tests, we're not going to pay for any of the following procedures for these clearly erroneous tests. And so the problem with being Dr. Pangloss is that without doing the right things first, we're going to set ourselves up where we're going to besmirch all of the genetic medicine of the future at the cost of hyping it today prematurely, Dr. Pangloss. And I want to return to the Undiagnosed Disease Network to say, we see this incidentalome throughout our patients. The reason why it's so hard to diagnose patients is we see loss of function mutations throughout the genomes of our patients. And the trick is actually figuring out which one of the 50 textbook mutations are the ones that are, in fact, causing that disease. It's not that it's hard to find a cause, we find 50 causes. So that's my rebuttal, Mr. Poopyhead. All right.
Did you talk about genetics?
Yes, I did talk about genetics. All right, now is it time for the,
Now it's, yeah.